Hello, and thank you for joining this OncLive peer exchange titled Advanced Pancreatic Cancer, The Road to Personalized Care. Pancreatic cancer is a disease with both a high mortality rate and increasing incidence. Thus, there's a critical need to develop new treatment options for patients with advanced disease. We're beginning to make progress by refining the use of combination chemotherapy and new strategies for sequencing therapy. We are now entering an era where we are learning more about molecular differences and driving mechanisms among pancreatic cancers with the hope of identifying personalized strategies for patient subsets. For the community oncologist, it's more important than ever to keep up with the new research and understand the options for clinical trials. In this OncLive peer exchange, I am joined by an amazing panel of experts in the field of gastrointestinal oncology. Together, we're going to work to provide you with a perspective on recent advances and what they mean to the care of your patients for the weeks ahead. I am Dr. John Marshall, and I'm Chief of the Division of Hematology Oncology at MedStar's Georgetown University Hospital, Professor of Medicine and Oncology at Lombardi Comprehensive Cancer Center, Georgetown University, and the Director of the Otto J. Rusch Center for the Cure of GI Cancers in Washington, D.C. And participating with us today are not only distinguished panelists, but really very good friends. Dr. George Kim, a GI oncologist in Jacksonville, Florida. George, welcome. Thanks for joining us. Dr. Kabir Mody, Assistant Professor of Medicine and Consultant for the Division of Medical Oncology, GI Malignancy Program, and the co-chair of the Mayo Clinic Hepatobiliary Disease Group in Jacksonville, Florida. Kabir, welcome. And Dr. Eileen O'Reilly, Attending Physician and member of Memorial Sloan Kettering's Cancer Center in New York, New York, and Associate Director of the David M. Rubenstein Center for Pancreas Cancer. Eileen, welcome. Dr. Tanios Bakai-Saab, Professor, Mayo Clinic College of Medicine and Science, and Program Co-Leader of the GI Cancer Mayo Clinic Cancer Center in Phoenix, Arizona. Tony, welcome. Eileen, we're going to let you give us a start here. You know, this whole ASCO where we are today is themed around precision medicine, personalized medicine, molecular characteristics. Can you give us a little high-level look of where we are in molecular medicine, maybe some data around molecular medicine in pancreatic cancer?
So John, this is a very exciting topic in pancreas cancer. We're now beginning to be able to refine treatment choices for patients. And to give you a couple examples of this, the BRCA subgroup, so people with germline BRCA, it's about 6 to 7% of people with unselected pancreas cancer. We now have pretty unequivocal evidence, I would say, to support the use of platinum-based therapies, and in the in the pre-treated setting, a role selectively for PARP inhibitors. We're also looking at PARP inhibitors as maintenance therapy. So that's one group. A broader group of patients with homologous repair defects is beginning to be defined. So learning to know whether patients with somatic BRCA mutations, with ATM, with CHEK2 mutations, whether these will also benefit from that strategy.
So George, I mean, we're talking about this. Do we know how to measure this BRCAness or HRD, as Eileen?
Yeah, I'm a little critical of this. Eileen and I have had a lot of discussions this weekend, but I don't know. I mean, I think we need to do more work. Obviously, the germline mutations are there, and that's pretty clear.
So
but what are the other ones?
Good, strong family history, but ultimately molecular testing to confirm that.
Yes, and we need to validate it. It's like every other predictive marker in GI cancer. We need to do a little more work, a little more homework, and really nail down what are the aberrations that are important. So
yeah, there are a lot of genes that are in the literature around BRCAness and the whole HRD pathway. We did a sort of broad look at some big gene data sets that we had and found that about half of those that are in the medical literature aren't ever expressed in actually patients, so they become irrelevant ways of measuring this. Would you say next-gen sequencing is what we need to be doing to figure this out? Yeah?
I think so. I mean, there's no clear definition of what's actionable yet in pancreas cancer beyond a few very specific events. The other key one to note, even though it's rare, is the 1 to 2% of patients with mismatch repair deficient or MSI high pancreas cancers. And work from our group has suggested that they mostly are people with germline Lynch. We see relatively few somatic mismatch repair deficient malignancies. So I think we have to keep that group in mind. And the other, approach to think about with regard to next generation sequencing is what trial options there are for patients. So, you know, if there's a BRAF mutation, occasionally we'll pick that up. Patient with an NTRK fusion, they're actionable events. Rare,
So there are a
but
lot of
important.
these one or less than 1% items that are coming forward where we have really, really cool drugs. I'm just betting that the Mayo Clinic patient is very interested in immunotherapy. Kabir, are you getting a lot of these folks coming in and saying, you know, I've got pancreas cancer, I want one of these new immunotherapy drugs,
absolutely.
and how are you dealing with that?
Well, I mean, you know, you sort of have to share with them at least the existing data and do some education on their part, because they're hearing this from all sorts of sources outside without the sort of knowledge of what types of cancer they're talking about in that literature, or those results that are being, you know, advertised and that sort of thing. But I think one thing that is notable is that we're seeing a little bit more in the way of subtyping of the disease, whether it's genomic or histologic. So the COMPASS study looked at classic versus basal cell subtyping, and then we had Andrew Biancon's group talking about 4 different genomically based subtypes. But you know, those sort of are a little bit away from the clinic, obviously, because we don't have a practical assay that is translated to clinical practice yet. But it's sort of getting there, hopefully.